Bert, let's go back to religion here and talk about refractory disease. And we've had some new data over the last year or so on some of our newer agents. Could you review for us the reverse clinical trial? This is back to Wells's point earlier about sequencing, and is there one right way to do it?
Yeah, I would say reverse for me was one of the bigger surprises of the last year. This is a small randomized Japanese study looking at sequencing cetuximab and regorafenib, and asked a relatively simple question: which one should you give first in patients who'd already had chemotherapy? They actually demonstrated a survival advantage for giving regorafenib first, followed by cetuximab over the opposite sequence. Again, it's small. I don't know how much weight to put on that, but they had a particularly long progression-free survival on cetuximab in the patients who had been treated with regorafenib first. So is there some biology there? I don't know. It's very interesting, and I think maybe will lead to larger studies that would be more definitive there.
Yeah, I've never seen regorafenib really catch somebody who's falling, the way I put it, but in a patient who's doing well, or a small volume disease, those are the patients that might have the sort of more controlled experience with it. But the dose, we hate the dose. So the redose study, Gabby, so looks at, is there a better dose and schedule for that? You want to review that clinical trial that Tony did for us?
Yeah, I'd be very happy to. So I think that way too often, especially for those of us who do a lot of phase 1 trials, we are used to the 3+3 approach, and sometimes the drug companies choose to move forward a dose of a drug that's maximally tolerated, despite maybe pharmacokinetics indicating that the lower dose might be achieving the target, etc. So sometimes, again, we are pushing drugs too far. And I think what the redose trial tried to see is, can we start with a lower dose of regorafenib and gradually increase it week by week as long as patients are able to tolerate, and compare the low dose start with a standard dose of 160 milligrams for 3 weeks on, 1 week off, and see really how many patients can tolerate, how many can move on beyond 2 months and stay on treatment, as well as then look at progression-free and overall survival. So the goals were really starting low, don't lose our patients due to adverse events in the first 2 weeks because they just simply can't tolerate the drug, and give them the benefit of being treated. So what we observed, number one, is there was at least as good of a progression-free survival with starting low at 80 milligrams, advancing to 120 that second week, and then to 160. Some patients that don't tolerate more than 80, they were allowed to stay at 80 milligrams. And the progression-free with low dose was 2.5 months versus 2 months with a standard dose. But the overall survival was about 9 months with starting low versus only 6 months with a standard dose, which reproduces the phase 3 regorafenib study. The toxicities were better with starting low, the hypertension specifically and the fatigue. So I think that study taught us that using a judicious, careful dosing of our patients and not really pushing the maximum dose is very important to really allow them to tolerate and allow their quality of life.
Just change your practice at all these 2 studies?
The first one, no. The reverse definitely does not, and the redose does, because I think when you're having a limited benefit, which is important for some patients, it's important not to tax them with quality of life issues. So I'm not sure, however, with the redose that there is that much of a difference in, the OS difference is a little bit out of line with the hazard ratio of the PFS, but I'm happy enough that the PFS is the same. And even if there is no difference in outcome, I think this is important because, toxicity is an issue.